Welcome. Today we have with us Dr. George Stavros, who will be presenting Mental Health 101, Caring for Emotional Distress in Pastoral Ministry. Before we get started, I wanted to review a few housekeeping items. During the presentation, you can send Dr. Stavros questions by clicking on the question mark on the left of your screen. This is being recorded and it will be posted in about a week. We'll notify people via Facebook once it is live. So today we have with us Dr. George Stavros. He's the Executive Director of the Danielson Institute and Clinical Associate Professor of Pastoral Psychology at Boston University. Dr. Stavros is a licensed psychologist and a certified pastoral counselor, and he frequently presents to church, clergy, and professional audiences on the connections between Eastern Orthodox theology and depth psychology. He earned a Master's of Divinity from Holy Cross Greek Orthodox School of Theology, and he and his wife, Despina, are parents of 4 daughters. Welcome, George. We're happy to have you here with us today.
Thank you very much, Melissa. It's a pleasure to be invited in, and I want to thank the Center for Family Care for the invitation. And this is my maiden voyage on webinar, so I apologize for any missteps I take, but hopefully we'll have a chance just to walk through some information about mental health and caring for mental health needs in the parish setting, and we can do some interacting through the questions that you all ask, and we'll just see where we get to from there. All right, so what I'm going to do is I'm going to kind of go back and forth between some PowerPoint slides, and I'll be talking my way through them, but I'll try and bounce back with my face in the PowerPoint so it's not just looking at words. And again, if you all have questions, please ask them through the chat function, and I'll probably be answering most of them towards the end, but I'll be able to take a look at them as we go. All right. So let me pull up our slides and we'll get started. So the title of our talk is Mental Health 101, Addressing Psycho-Spiritual Needs in Parish Ministry. There's no perfect language for talking about this stuff, but I should probably disclose a little bit of my bias. And that is that psychotherapy and the idea of mental health is a fairly modern concept. You know, it's maybe 100 to 150 years old. And before that, there certainly were still mental health needs and mental health issues in human communities. It's just part of being human that things like stress and trauma and loss and biology and genetics all make us more or less vulnerable to emotional disruption. And those issues 150 years ago were held much more within religious community settings. And so the accumulated wisdom of thousands of years of dealing with mental health issues counts in a big way when it comes to thinking about what it means for a person to be mentally or emotionally healthy or to be struggling. So my bias is that whatever language I use that sounds more or less shrinky has its roots in the life of the church. And I'll try and make some connections along the way, but this talk really is going to be more based on how to seek out good mental health resources through the parish. All right. So we have a couple of objectives and goals for today's talk. Let me just go through them one at a time. The first is I will provide some examples of actual mental health issues as they've been presented in Greek Orthodox parishes. These are things that through different opportunities to talk with parish priests, parish councils, counselors who work closely with Eastern Orthodox communities have actually come up. The specifics I will have changed a little bit and made very general so that there's nothing that would indicate who who we're actually talking about, but these are things that actually are happening and being worked with in Eastern Orthodox parishes. We'll talk a little bit about the prevalence of mental health issues in America, just so we have an idea that it's common. It's people are constantly exposed to things that are challenges to mental health and seeking out resources to get support. We'll outline the importance of pastoral ministry to those with mental health problems. We will outline the need for training for clergy and parish leadership around mental health issues, and provide structure and strategy for developing strong mental health referral resources for your community. All right, so for starters, some stories from the parish. An unbaptized construction worker contracts AIDS and approaches the priest for pastoral care. Couple things notable about this one. The first is that the priest who told me about this did not have any previous contact with this construction worker, and the construction worker had some childhood background in Orthodoxy, but really had not had any church life up until this contact with the priest. A second thing I want to point out about this particular example is that in general, clergy and people in ministry at the parish level are the front line of ministering to those with mental health needs. The reality is that formal mental health professionals in treatment can often be 1, 2, 3, 4 steps down the line for someone who is in need of mental health treatment, and they're much more likely to show up at the parish seeking help. Next example. A depressed adult female parishioner confesses her acute suicidality but swears the priest to secrecy. This is not, again, not an unusual situation in that oftentimes to speak to someone about intense emotional suffering, one of the things that we find in the mental health field is that it can often be accompanied by quite a bit of hesitation and even shame. And so the idea of disclosing it and the fear that that disclosure will then be passed on to someone else is something that needs to be managed within the parish setting, because secrecy is not always the best thing. And so for pastoral caregivers to have a language that they can use about why it's important to include specific other people in a timely way can often be very important. The parish council deals with a disruptive male parishioner with mania and religious delusions. It is, again, a pretty common scenario that people with acute mental health symptoms come seeking help in a parish setting, but their symptoms themselves can often be a source of disruption, and having a way to compassionately address those is often a very important part of parish life. A depressed and anxious teenage girl is physically assaulting her younger brother. Issues of domestic violence, of depression, anxiety, as we'll see a little bit later in the talk here, are pretty common. And having a way within the parish to hear those things out and to have some ideas pretty quickly about resources that are available can often make a huge difference between situations like this one escalating or people finding help and de-escalating them and helping people restore more stable, more supportive, more loving relationships. A husband and wife are physically beating each other on a regular basis. Oftentimes, situations like this that can feel on first pass so out of control, with some training around how to intervene and what the resources are for people to access, can slow things down, can stabilize them in a way that prevents further damage from being done. The whole idea around early intervention, which is a big concept in education and early child development, but it applies just as much to mental health issues, is crucial, because the sooner acute symptoms can be brought under control, the easier it becomes down the line to know what it is that helps and what it is that helps people reestablish stability and safety. A troubled parish family with 2 young children moves to a dangerous neighborhood where their landlord is selling drugs out of the home. So when we talk about mental health issues, we're not just talking about what exists within one person, a set of symptoms somehow that affects one person. We're talking about families, parents and children, spouses, communities, and the kinds of vulnerabilities and resources that exist at all those levels. What we'll talk about a little bit later in the talk is how to access at multiple levels the kinds of resources that can be helpful in a situation like this. All right, so how common are mental health issues? If we take a look at this chart, we can see that in any given 12-month period, 26.2%, that's more than 1 in 4 of U.S. adults will report a clinical level of mental health symptoms. That's 1 in 4 over any particular 12-month period. Excuse me. In terms of severe, 22.3% of these cases would be classified as severe. And that, that can mean something that's completely debilitating, like a psychotic break, like a suicide attempt, something that can be completely incapacitating, really can be affecting 22.3% of the 1 in 4. So that's about 6% of adults in the U.S. What we find is, while there may have been a time that those numbers would be less in Eastern Orthodox communities, that's not really the case anymore. There's kind of a mainstreaming effect as these communities move further away from a more immigrant experience. And even earlier on, what some of the thinking is that these kinds of symptoms were still present, they were just handled differently. So within Eastern Orthodox parishes, 1 in 4 adults, and of those 1 in 4, another 1 in 5 will have serious symptoms. So what does that look like? Let's just think about it in terms of what the numbers would look like within a parish. So let's say the parish is a smaller one, a parish of 200 families. That means if you looked at those 200 families, 57 people amongst those 200 families will be suffering from mild or moderate psychiatric symptoms, the most common of which are depression, anxiety, and substance abuse. Again, over 1 in 4. 18 of the 200 will be suffering from severe psychiatric symptoms, things like schizophrenia, bipolar disorder, or serious addiction. So we don't have to look far. And very often, there's a kind of silent suffering that goes on at the parish level. In talking with priests and parish councils over the years, what's been talked about is something that they've described as the coffee hour effect. And the coffee hour effect is that many parishioners come to church and are trying to put on their best face. In other words, they are bringing to the parish the most acceptable part of themselves and trying to deal with the suffering emotionally and from a mental health perspective outside of the experience of the community. We talked about how much shame is a part of this, as well as the idea that religious people somehow are supposed to be doing better than the rest of the world. But the reality within our parishes is what you see in front of you, that for any given parish of small size, there are significant numbers of people who are suffering mild to moderate symptoms, but there are also quite a few who are suffering severe mental health symptoms. And so a kind of awareness of this and an openness to dealing with it in a more direct, loving, accepting way is crucial. All right, so how do we think about addressing mental health needs within a pastoral ministry model? Number one, maintain a pastoral relationship. There are so many good reasons for this being number one. The primary one really emanates from our Eastern Orthodox theology of the Holy Trinity. The Holy Trinity is a way of, in the best way that we can with our human limitations, of understanding that God, the creator of all, the author of life, is both a unity, one God, but also a trinity of persons, three persons, Father, Son, and Holy Spirit, and that the love relationship that is constantly and perfectly flowing amongst the persons of the Trinity, Father, Son, and Holy Spirit, is a reflection of all reality, and more specifically of human reality. So we can only be ourselves in relationship. Therefore, if any healing is going to take place, and emotional healing is a key aspect of this, it's going to have to be mediated through a relationship. From a mental health perspective, the one finding on psychotherapy and its effectiveness has nothing to do with the kind of therapy, whether it's cognitive behavioral therapy or family therapy or group therapy or psychodynamic therapy. It's not the kind of therapy, it's the quality of the relationship between the therapist and the person receiving therapy. That is the number one finding, that if that is not in place, nothing else is going to happen. So number one, maintain a pastoral relationship. Second, orthodox rhythms of worship, sacramental life, pastoral care and counsel, visitation, and community life can be vital lifelines and restorers of emotional and spiritual health to parishioners struggling with mental health issues. A prominent trauma clinician and researcher in Boston named Bessel van der Kolk makes the point again and again and again that in the face of trauma and great emotional suffering, it's not possible to simply talk our way out of feeling bad or talk our way into feeling better. That ultimately, the way a human person who is suffering emotionally gets better is through a large range of things that are relational, that are rhythmic, that are embodied. In other words, things like anointing with oil, worshiping in the context of many images that penetrate all the senses, receiving Holy Communion, doing prostrations during worship, remaining active and vibrant within a community, working within a community, things that engage a person both relationally and physically. That's how people get better. And the church, I think, in her wisdom, has known this for a long, long time. This makes it really important that people who are experiencing mental health issues and symptoms find ways to stay plugged in to the basic rhythms of worship, sacramental life, pastoral care and counsel, visitation, community life. When we talk about them being vital lifelines, we're talking about them being life-giving and life-saving and life-restoring. So let me just take a quick clarifying question regarding the numbers on the number of people who suffer from emotional symptoms at the parish level. Our question is whether those numbers relate to families, 57 families or 18 families, or individual persons. Those numbers relate to individual persons. So I think the assumption was maybe with 200 stewards, let's say we're talking about maybe 300 to 400 people. Those numbers come from there. Okay, and finally, the way in which mental health needs can be helped and supported within pastoral ministry is through things like retreats and workshops. Retreats provide just what the word says, a chance to pull back and experience a sense of community and rest and a change in the kind of hectic nature of life that really can exacerbate mental health issues. Workshops can be a source of education and fulfillment. I would say that one of the most valuable ministries taking place in American Eastern Orthodoxy right now is in the various camp programs that are thriving throughout the country. There's something about the combination of active lifestyle, community, worship, and rhythm that seems to set something healthy in motion for so many children and young adults and the counselors who serve them. The camps are run by and served by staffs of young adults, but I'll tell you what, I think if you ask the staffs, those young adults are getting just as much, if not more, out of the experience as they feel like they're giving. And this may be a little bit of an exaggeration, but I'm going to say it anyway. If I had $1 right now to give to only one thing within American Eastern Orthodox pastoral ministry, it would be to build up those camp programs, because it's an investment in the present and the future of our communities. If I had a day to give of myself to some pastoral ministry, it would be to go and serve for a day in camp, because there's a way in which the ministry there incorporates so many things that are good for the whole person. Okay, let's keep moving along. All right, so training in mental health issues. How do we get some basic level training? Here's one resource that's out there. It's called the Mental Health First Aid Program, and I've included the link here in the slide. This is something that does a few frontline basic things in a way that's pretty doable and accessible by people without a lot of mental health background. It trains people to assess for risk of suicide or harm, to listen non-judgmentally without quick advice giving, to give reassurance and information. And that combination has been shown to be particularly important and powerful for people. If these things are separated, somebody may benefit from it, but the combination of reassurance, that non-judgmental listening, and then something they can do about it, it's crucially important. Because in the context of so many mental health problems, what people experience is that their will or their initiative or their motivation has been compromised, and to be given some specific information that helps them gain some beginnings of control or mastery over their situation, it can be crucial. The mental health first aid program also encourages appropriate professional help, and finally encourages self-help and other support strategies. So this is a good, very accessible resource for people in pastoral ministry to access and just educate themselves so that they become a first-line resource to people presenting mental health issues in the parish. Another website that has a lot of resources is through the government. It's the website for substance abuse and mental health, and it has a full range of things for specific disorders, specific symptoms, and specific treatments to address those things. A very comprehensive resource. Another resource is mentalhelp.net. It's something that both people who are ministering to those who are experiencing mental health issues can access, but it can also be a resource to the people who are suffering themselves. Mentalhealthministries.net is a place that attempts to be more specific or explicit in addressing mental health issues within ministry. Okay. Let me cut over to a question that's just come in. Let me read it to you, and I'll comment on it. So the question is, we're often told in seminary, if particular issues can't be resolved in a small number of meetings, it should be handed over to a professional. With every case being different, how can one give a timeline to such care? For example, this must take 3 or 4, then it's time for someone else. I think that's a great question, and what I think about that particular idea is very much that it's a guideline, and what it's trying to suggest, my guess is, if something can't be resolved in 3 or 4 meetings and seems to be escalating or seems to involve a level of emotional suffering that is so significant and so serious that it doesn't make sense for there to be fewer resources. It makes sense for there to be more. And so in a way that pastoral ministry can be combined with professional resources as well. As you can see on the text of the next slide, we're talking about never worry alone. So I wouldn't approach a pastoral care situation from the standpoint that, well, if I haven't somehow taken care of things in 3 or 4 meetings, I need to let go of it and pass it on to somebody else more specialized. As a matter of fact, I think the degree to which pastoral caregivers can be the ones who are in it for the long haul, and somehow, if there is the need for a referral, to say something like, you and I are in this for the long haul, but let's get some more specialized help on board to provide more rather than less. I think that is exactly the way that many situations can be handled, because, as we said, relationship is the key to providing the platform and the vehicle for a person's mental health well-being. So it's really something that's based on the level of acuity of symptoms and whether there seems to be some escalation of the symptoms or deterioration of the person's well-being. Also, there was some consideration about whether monasteries provide some of the same kind of holistic holding that retreats and camps can. And I have less experience with monastic settings providing that from a direct standpoint, but I can tell you that not so much in the United States right now, but I have heard of monastic communities in Greece establishing clinical sites for things like substance abuse treatment and mental health care, and that they actually use some of the rhythms of monasticism as a way of providing the combination of relationship and structure that really helps people. That's a more specialized example. My guess is, with any healthy monasticism, the wisdom of the church that is expressed through that healthy monasticism is exactly what people need and provide the same kinds of things as camp and retreats. All right, so let's go to Never Worry Alone. Number one is to develop a referral base of clinicians. This probably sounds straightforward. It really isn't. I'll say more about that in a minute. Identify community mental health resources. Identify community services and agencies. Let's start with the mental health clinicians. All right. So if somebody seems to need some kind of mental health intervention, some psychotherapeutic intervention, how do we go about that? Who would we refer to? This is under the first thing, is finding a referral base of clinicians. There are psychologists. Typically, psychologists are doctorally trained, PhD or doctor. Another degree is called a PsyD, a doctor of psychology, who have a lot of training in treating people who have clinical levels of mental health symptoms. This used to be probably the most common training that a psychotherapist had. There are still a lot of psychologists out there, but that's one discipline within the psychotherapy providers. A second one is social workers. Not all social workers are trained to be psychotherapists. The ones who are have a particular degree, or not a particular degree, a particular licensure. It's called licensed clinical social worker. It means they've done a kind of training that qualifies them to be psychotherapists. In many states, they have an even more advanced kind of credential called a licensed independent clinical social worker. Marriage and family therapists. This is a discipline of specialized training. People who are trained specifically not just to look at the person and their suffering from a symptom standpoint, but from a system standpoint, that any of us who is suffering emotionally is doing so within a context of existing relationships, family, culture, social, religious, and so their interventions tend to be at the couples level and the family level. Substance abuse counselors are basically what you would imagine. They deal with substance abuse issues specifically. It's important to have a group of child specialists, people who who are trained specifically to work with mental health issues in children. That could be psychologists, social workers, psychiatrists, even marriage and family therapists, but not every psychologist, social worker, or psychiatrist is trained to work with children. This is a tough one because there aren't enough people who are trained to work with children, and the ones who are trained to do so oftentimes have long waiting lists, sometimes won't even take insurance because it's too much of a hassle for them to do all the billing, and so they can be hard to access. So in any given community, it's important to find some of these folks so that they're available to the community. All right, so if there's one takeaway on this whole mental health clinicians thing, when putting together a parish's referral book, the mental health providers to whom people within the parish can be sent, it is so important that the group be put together by direct experience rather than internet search or the kind of lists that insurance companies pass out. This is I by no means intend to be overly critical of of my field, but as with any field, not every mental health provider is going to be a good fit, and for a group of people for whom faith is important, it's important that those providers be people who are sensitive in working with people's faith and their faith lives. So word of mouth is important, and not just word of mouth, but having professionals within the community also being sources of identifying referral. It can be complicated in any parish to have people within the parish providing mental health resources because it's hard to have a dual role. It's actually discouraged within mental health provision to have a dual role, to be co-parishioners or to be friends and to also be working together in a therapeutic sense. So while I would in general discourage people from seeing fellow parishioners for mental health needs, I would strongly encourage mental health professionals within a community to identify their best colleagues to make up that referral group. All right. Spiritually integrated psychotherapy. This is a bit of a movement right now. There used to be a lot of antagonism between religion and mental health. That's really dissipated quite a bit, and there is an emerging group of mental health practitioners who are specially trained to be very sensitive to people's faith and spiritual lives. Where can you find these people? Here are a couple ways to look for them. Not in every city, but in some cities around the U.S., about 90, there are what are called Samaritan Institutes. You can look at that website and see if there's a Samaritan Institute somewhere in proximity and see about making some contact with them. What I would suggest is if a community is looking to establish a referral base, have somebody from the community go talk to the clinical director of a Samaritan Institute, discuss the needs of the parish, and try and think about ways to set up the availability of these spiritually integrated counselors. So that's one possibility. The American Association of Pastoral Counselors is a nationwide, actually includes Canada as well, collection of professional counselors who are trained in pastoral counseling specifically, again, to take people's faith lives seriously. And the website wherein you could do searches for people who are part of this association is right there. Again, blind searches, I tend to be a little bit hesitant about, but the combination of that credential and somebody else's independent approval of that person, that's a great combination. All right, another level of mental health care is not psychotherapy, it's psychopharmacology. This involves the provision of psychiatric medications. Again, this is a very sensitive topic. It's not something that oftentimes is easily talked about, even though there are a lot of people that receive these medications. My sense on this one is no different than with the psychotherapists. Don't go to just any psychiatrist that you find in the phone book and hope that it goes okay. Word of mouth, word of mouth, word of mouth is the way to go with mental health providers. And if you need a question to ask, let's say you have mental health providers in your community, or you know of mental health providers through your own profession, the question that I would always ask them is, who would you send your family to if they needed psychotherapy? Who would you send your family to if they needed a psychopharmacological evaluation? Make it that specific, and build a book of resources that the community can have and access in the event of mental health issues. All right, so psychiatrists are psychopharmacologists. They have board certification in psychiatry. They are the top level of provider for when it comes to psychopharmacology. There are also specialized nurse practitioners and clinical nurse specialists whose training allows them to prescribe psychiatric medications. Any nurse practitioner can write a prescription, but there are only a subset of nurse practitioners who are specifically trained around psychiatric medications. Again, combination of specialized psychiatric nurse practitioner combined with that, who would you send your family to? General practitioners are prescribing more psychiatric medications than ever. On the one hand, this is an important thing because sometimes people never make it to a psychiatrist or a psychiatrically trained nurse practitioner. They go to their doctor and say, I'm suffering from depression or anxiety. In many cases, this works fine. But the more serious the symptoms, the more specialized the need. So just consider that. All right, another level of mental health treatment is treatment facilities. How do we find these within our communities? Psychiatric hospitals are the highest level of care. They typically provide inpatient care for people experiencing psychiatric emergencies and major acute psychiatric episodes. They're not all of the same quality. So again, get to the professionals, ask them, if you had to hospitalize your family member, where would you want to send them? And there are going to be issues around insurance, and different insurances will send people different places, but first find out where the professionals would send their family members, and put that at the top of the list. Psychiatric emergency rooms. Any emergency room is really set up to be a psychiatric emergency room, and this is a level of care that comes about in the event of an acute crisis. A major development of acute symptoms of mania, psychosis, depression, suicidality. Sometimes there needs to be a quick intervention and a quick provision of safety. This can be done by taking someone directly to an emergency room, or any police force combined with emergency response people can get a person to an emergency room. Obviously, this is not something you want to pull the lever on quickly, but if there's an emergency and life-threatening circumstances, this is how to get somebody into care, is through a psychiatric emergency room. Then there are outpatient mental health clinics that typically are places that provide regular therapy. Typically, that could be once a week, that could be every other week, but they provide psychotherapeutic care along with psychopharm care. Community mental health centers are in most communities. The metric around these things is the same, though. Ask around, where would you send, and maybe where would you not send your family if they needed mental health care. Substance abuse treatment centers are specialized around treatment for addictions. And then there are local services that people are going to need. Remember the last example from the parish where the mother and the children moved into a house where drugs were being sold, and there was just a basic community level risk. So emergency shelters, it's good to know where they are, where the better ones are, what happens there, which ones have programming and which one are just for, you know, more acute overnight care. Safe houses, this is typically for battered women and families, but these are places that will provide some containment and protection in instances of domestic abuse. Ask around, find the better ones. Most cities have something like this. Survivors resources, this is something we heard about from the Twin Cities, where the families of persons who have died violently can go and receive counseling around the inevitable trauma that they are experiencing in relation to that loss. There's something in Cambridge, Massachusetts called the Victims of Violence Program, which is for people who themselves have suffered some sort of violence or trauma, where specialized care is offered around that. These more specific ones are just examples of things that exist in some places. There's no guarantee that something similar exists in every community, but there's a good chance something like this exists in most communities. So it's a good thing for people to be aware of who have a role in pastoral ministry, just to know what the resources are there in the community. All right, there are also state agencies. I'm going to tell you about some that we have here in Massachusetts. There are equivalent things in each state. So typically, each state will have a Department of Mental Health that deals with the more long-term chronic and debilitating mental illness and the resources those people and their families will need. There's a Department of Children and Families, typically deals with child abuse and neglect. Again, there's a version of this in every state. There's a Department of Youth Services, typically something that deals with the juvenile justice system. And there's a Department for Refugees and Immigrants. Again, all resources that have some version in some state. If you were, let's say you're putting together a resource book for your parish, these are the kinds of things you want to have names and phone numbers for access points at each of these levels. Okay, so that is it as far as the slides go. I know we have some questions that have come in, so I'm not going to be able to read those questions without my glasses, so if you'll excuse me, let's take a look at some of them and see what we've got. All right, let's see here. So, question. How can we get people to follow through on psychotherapy referrals? Oftentimes people come with acute mental illness issues, but they often either don't think that they're serious, or they don't follow through, or they just go a couple of times and don't follow through. It's still a difficult circumstance. Well, that experience actually is pretty consistent with any mental health referral. It's very it's not a guarantee just to get somebody to go once. There's a statistic that gets thrown out in shrink school, and that is the modal number of psychotherapy sessions, the most often occurring. If you looked at 100 people who went to get psychotherapy services, out of that 100, the greatest number of them, you know how many sessions they have? 1. So what you're describing there is common. There's also another thing that they teach us in shrink school, and that is the #1 goal for the first session of psychotherapy is a second session of psychotherapy. This goes back to that idea that the relationship is the vehicle for change. It doesn't cause the change all by itself. Obviously, training and technique is vital. So, in developing resources for psychotherapy provision within a community, it's just important to try to really get the best of the best through that word of mouth, who would you send your family to process. It's no guarantee, but as with so many things, just that initial contact is so important. So I want to express my appreciation for you making those referrals and trying to keep, resources moving into and through people's lives, but I appreciate the struggle there. Okay, let's see. Somebody makes a comment that a parish nurse could be a good role to delegate responsibility, and if they could be a licensed RN and work for the parish, that might be an asset. You're not kidding. Not a lot of places use parish nurses or parish nurse services, but you want to talk about the ultimate triage function for parish ministry. That model has been very successful in the few places in the Orthodox Church where it's been used. I know it's used in other denominations quite a bit as well. But a spiritually sensitive, clinically astute parish nurse could be a great referral source, and could also be someone who's in the medical and mental health community who can help identify resources beyond the parish. Okay. Let's see. What is appropriate for a priest to do in the context of confession if the person indicates he or she is planning suicide or harming another person? Oh, that's a really good question. Well, the necessary understanding of privacy, confidentiality, containment, however you want to talk about it, in the confessional, it's indispensable. Typically, somebody can't go to confession being worried that what they talk about there is somehow going to jump the container and that information is going to go somewhere else. But when you're talking about this level of acuity, I have two thoughts. One is, in the context of the confession, a priest has the latitude to work as gently and with as much pastoral sensitivity to maybe within the confession say something like, this level of suffering, if they're concerned about the dangerousness of it, we simply have to bring in more resources. So it's not like there's a button to be pushed secretly and silently that brings in the emergency medical staff. But I think it's something, if the priest has a level of concern that goes to the point of someone's life, that they need to be able to use the confessional flexibly, or maybe even somehow use the power of the confessional to find a way to get those other resources into that person's life. And it's much easier said than done, but when somebody's life is on the line, I think there needs to be more room to respond flexibly. Okay, let's get another one. All right. So a couple of resources out there that other people are aware of that I'm going to let you all know about. I don't know about them myself. One is the book God's Path to Sanity. The author is D. Pennock, P-E-N-N-O-C-K. It sounds like there are people out there using that in the parish. I don't know of that resource myself, but I just want to make you all aware of it. Another one, some Baptist churches have the Stevens Ministry. I have heard of that. I think it's a way of bringing in people with skills outside who are parishioners into the parish to serve out of those skills. From a mental health perspective, there probably are ways to develop that. Again, I would be careful around the clinical boundaries that develop within a community amongst parishioners, but certainly a huge part of stewardship is finding some way to use our own gifts and talents. And if people have mental health gifts and talents, there have to be ways, creative ways to use those within the parish. All right, let's see. Question, are all human beings mentally ill per our theology? How does a pastor know when a referral is in order and emphatically to encourage it? Great question. So, some of it comes down to terminology, and we're talking about different disciplines, because certainly I think theologically our understanding is that we all live within a fallen world, and we all have the impact of that fallen world taking its toll on our sense of well-being, our connection with God, our awareness of God's love, our capacity to be stewards of that love, and how that gets, that's been affected all the way back to the fall from paradise. So everyone at some level is struggling with that level of emotional disruption and brokenness. How to determine whether or not professional services would be helpful? I think the first criterion is obviously if there's something life-threatening about those symptoms, absolutely. Acute crisis requires more services and more containment. But there's also the statistics within the mental health community are that 70% of people who go for therapy on a first pass just to get helped by it. Not fixed, but get something from the experience that enhances their mental well-being, their emotional well-being. The way to raise those odds above 70% is, again, around the quality of the referrals, the fit of the referrals, and, believe it or not, the resources that stay in place or even get built up more within the parish in conjunction with those services. So while one model might be, all right, somebody's suffering from mental health symptoms, they need to get help, and that somehow removes them from the community, it's going to run against what helps them. If it's they need help so that they can actually make more use of the community, so much the better. Okay, I think we have time. Let me get one more question. Okay, so one question is, can we get these PowerPoint slides? The short answer is yes. I'll make them available to the Center for Family Care to be distributed. And last question, let's see here. Oh boy, that one's going to require a longer answer. I actually think we're running close to our time. Okay, let me do this one. Can psychology coexist with religion during therapy? Again, the short answer, absolutely, and it should. It doesn't happen by itself, though. It will only happen in as much as the practitioner is prepared for and trained to do that. Those traditions of healing, faith and psychological, are meant to be intertwined, because you don't want to break a person into pieces in order to help them become more whole. But it's not a given within the mental health community. It needs to be within the practitioner. That's why that referral base is so important. Okay, I realize we're about out of time. I'm going to send it back now to Melissa Songranis from the Office of Family Care. Again, I am so grateful to you, Melissa, and to the office for the chance to do the webinar, and that's all.
And we're really grateful to you, George. It was a really wonderful and insightful, helpful presentation for everyone, I'm sure. We also want to thank Leadership 100 for their constant support of our ministry and allowing us to offer these webinars to everyone for free. This is a beginning conversation. Hopefully we'll be able to discuss this topic more. We just kind of scratched the surface with this, and hopefully we can continue to offer things on this topic down the line. I want to remind you all that, again, this will be available to be watched about a week from now. If you're interested in passing that link on and sharing this presentation with others, about a week from now, you can like us on Facebook and you'll be notified when it's available, or sign up for our listserv, and that will also let you know when it's available. You can find our listserv at www.family.goarch.org. Thank you all, and we look forward to seeing you next month.